Okay, welcome everybody. I'm glad you're here. We're going to cover SOAP and chart. These are required for your PCRs as a part of your program, so I hope to clear up any misnomers and make sure that you guys know exactly what's expected in your program in doing either SOAP or chart type of PCR documentation. All right, so the mystique of SOAP and chart is nothing that's out of the unusual. It's, we've been writing reports for ever since EMS started, and that report is extremely important for patient care and the continuum of care so that we can make sure we relate to the hospital everything that we've done for our patients in an understandable manner. Whichever one you use is up to you, and we're going to get into the meat and potatoes of it and hopefully be able to clear anything up that you may have questions over. All right, so EMETSEEI student PCR documentation. What is SOAP? Well, it's very simply, it's a form of written communication based on subjective, objective assessment and plan. Pretty easy stuff, not that big a deal. And we're going to go over that first, then we'll cover chart and which one do I have to use and how much information do I need to document. All right, so SOAP. SOAP is based on your subjective assessment. This subjective assessment is exactly what you're told or read. It can be also, this information is stated usually in the patient's own words, but it can also be any verbal communication from another provider, bystander, or something you read in a chart that you want to copy into your documentation. This comes in real handy, that piece, the chart, especially if you're doing interfacility transports. As far as the objective and the O assessment or objective assessment, this is what you see on exam. This is your actual hands-on and also your visual that you see on the exam, such as the position that the patient was found. Either they were prone or they were supine, they were left lateral recumbent, right lateral recumbent, any acute hemorrhage that you noticed when you were first walking up and what you did about it, basically. Acute disabilities, history of the present illness, and including past pertinent history. The A portion of SOAP is the assessment of the patient's condition. This is what you believe is wrong with the patient. A perfect example is if you have a patient that has chest pain, their subjective assessment, they're telling you, I've got chest pain. You can see acute chest pain, and that you're going to rule out AMI versus acute coronary syndrome. So that's a very simple way. This is a very short explanation, extremely short explanation. It's what your differential diagnosis is and what you're going to try to rule out. The P part of it, the plan, is your course of treatment and patient disposition at the emergency department, when you turn them over. Or at the end of care, would you say. Also, the vital signs are on there. Make sure you include any oxygen, SaO2, and tidal CO2, both 3-lead ECG and 12-lead ECG, interpretations, medications, procedures, and the transport method. And finally, what was their final disposition? Did you turn them over to, if you're non-transport, you'd be turning them over to a transport unit, or did you take them to a hospital and turn them over to a nurse or a doctor? And make sure that you're documenting that information. We're going to talk about it a little bit more, but part of that documentation is also very important that if you have patient belongings, who you turn those belongings over to. So chart, just a little bit different. Chart is based on the following components. There's a total of 5 of them. A little bit easier. A lot of people like chart versus SOAP. Either one, like I said, is fine. Chart stands for chief complaint. This is obviously stated in the patient's own words. Then H is the history of the present illness, including past pertinent history. And then A, that's the assessment, to include the results of your initial assessment and your physical exam. This is that primary portion of it, to include your general impression. Was the patient conscious, unconscious, sick, not sick, those kind of things. And then also RX, the R, or the treatment. This includes anything that you did for the patient and use somewhat of a chronological order from start to finish. I always like to start with, exam performed, vitals performed, what those initial and secondary vitals were, my primary exam, my secondary exam, and then my ongoing exams. And anything that I did, IV, oxygen, 12 lead, 3 lead, so on and so forth. I always put them in the order of priority. And then finally, T is transport and condition en route. Important. Any changes, your secondary vital signs en route, including the destination that you're taking the patient to, whether it was emergency, non-emergency, and any patient's change in their condition. All right, so which one do I have to use? Either one. I'm good with it. Hey, I'm easy to get along with. Not a big deal. You can use either one. I'm good with either one. No big deal. Just make sure, obviously, you're trying to give me as much information as possible. I always tell my students, you're painting a picture for me. I need to be able to understand that you understood based on the assessment module, the 5 components of the assessment, that you did it in a methodological order based on the patient needs, and you were able to apply critical thinking to form a differential diagnosis. You found your pertinent negatives, and you displayed a good organized manner of doing that assessment. That all comes out in the documentation. So paint that picture for me. Tell me what was going on so I understand exactly what you had and what you did about it. How much information do I need to document? Well, obviously, if it's a non-transport or a refusal, there's not a ton of documentation, but give me some information, especially why. Why did the patient refuse, and that you offered, to transport them or to have them transported, and you told them the consequences of, what could happen if they didn't go to the hospital, and most importantly, that you told them that all you have to do is, if you need us again, just to call us back. That is, stuff that a court of law loves, because if something does happen to the patient and they died after you left, you have in your documented report that you gave every possibility to take them to the hospital and inform them to call you to come back. Good stuff. All right, so let's tear into the nitty gritty of each one of these. SOAP, and also we'll do chart as well. Don't have a crystal ball. Everybody writes reports differently, so it's okay. I'm not looking for each one of y'all to write exactly the same, but you need to use the format. So let's start with S. S, your subjective assessment. Tell me what you were told. What did the patient say? Patient stated, I drank 25 beers. Don't ever say the patient acted intoxicated or I smelled ETOH, because in a court they'll say, hey, are you an expert? Are you certified to do that? Just simply put what the patient tells you. I snorted a line of cocaine. I did some MDA or whatever, ecstasy, some meth, whatever it is. Also, tell us whether this is a nature of illness or mechanism of injury or both. Also include, because the patient's going to give you this information, age, sex, weight, and level of consciousness. Level of consciousness is obviously based on person, place, time, and event. So give me that information, whatever you can tell me. Paint that picture so I can see what you saw when you were there and what they told you. Some of the assessment acronyms that we use in this particular portion into the subjective is we use very simple AVPU, sample, tacos. This is how we can describe different things. AVPU obviously is alert, person, place, time, or event, or they're verbal, painful, or unconscious. Sample, I think everybody knows that. Signs, symptoms, allergies, medications, PET, personal history, last meal events leading to or leading prior to your arrival. Tacos, not everybody remembers this one. It comes from your book. It's do they use tobacco, alcohol, caffeine, over-the-counter drugs, sexual or street drugs to include. Because, hey, if you're giving them nitro, you got to know these things, as far as like if they're taking Viagra or Cialis, those kind of things. Another piece of this is the abbreviations of the questions. CC, when you are laying out your SOAP and you're moving forward, CC would be chief complaint, past medical histories, PMH, PSH is past surgical history, PPH is past psychiatric history. Remember, Patient's telling you all this information. So this is where you document it, because they are telling you this information, and it's just a very concise, sweet way to do it. You put CC, patient complaining of chest pain, PMH, hypertension, hyperlipidemia, coronary artery disease, whatever. And then of course PSH, and then whatever their surgical history is, you'll document that. But it's a great tool to use. You can plan it right on there and then just fill in the information. Also continuing on, CSH, current social history. Basically, this is anything they want to disclose. And this is super important because of the fact, like for instance, if it's a geriatric patient, and they, your differential diagnosis, depression versus anxiety or whatever the case may be, if they don't have a social life, that could be very well leading up to it, and they could be depressed, and they could also be suicidal. So this is good questions to ask when you're dealing with a geriatric patient. Normal level of consciousness. Ask the loved one. This is helpful in a stroke. Anybody has an altered mental status, ask that loved ones, hey, is this the normal level of consciousness for your husband or your wife? Those kind of things. Tobacco and alcohol use, important to know because it gives us a general idea of their health and potentiality of the complications with the use of either one of those items. Sexually active. This comes into play anytime that we're, especially young, we're thinking, maybe she's pregnant or, that kind of thing. Or if we have a male that's got an itch of an unknown origin kind of thing. So important information. You're trying to dwell in, you're trying to get all your pertinent negatives put together so you can form a good differential diagnosis based on good critical thinking. Other abbreviations to continue on, obviously LMP is your last menstrual period. Don't forget pregnancy in females, gravida and para. Remember, gravida is how many pregnancies they've had, and para is how many live births that they've had. Meds, obviously allergies, last meal, and EP, events leading prior to. All right, moving on. Oh, the objective. This is what you see on exam. This is your physical exam. What was their position that you found them? Was there any acute hemorrhage? Was there any acute disabilities that you found? Those kind of things. In this, the acronyms that we use, this comes out of your book, AEIOU tips: alcohol, epilepsy, insulin, opaque, uremia, trauma, temperature, infection, poisoning, and psychogenic shock. There's also 5 additional S's: stroke, seizure, syncope, space-occupying lesions, and subarachnoid bleeding. Hey man, this helps us in our assessment. This is a wonderful tool to use to really dig into this when we're doing our differential diagnosis. So AEIOU tips is very, very helpful. Also, you have your OPQRST, DCAT-B, LS, TIC, PMS, and CR. As you can see, the acronyms have really good pieces of meaty kind of information. The first one, OPQRST, can be used for pain. It can also be used for respiratory difficulty. DCAT BLS is for our trauma patients, including TIC. PMS is for every single patient. Pulses, motor, sensory, both in the upper extremities, lower extremities, and don't forget capillary refill. It really gives us both these components give us a good idea on their circulation system and their neurological system. This comes into play with stroke patients, trauma patients, you name it. So make sure you're using it appropriately. All right, others, HENT, head, eyes, ears, nose, and throat, into augmentary, which is your skin exam, chest, abdomen, pelvis, GYN, URO, lower extremity, upper extremity, neuro, and initial vital signs. These are all pieces that we're going to use in our assessment. We have to describe each one of these areas. And what's really cool about it is that this gives us a roadmap. It gives us a roadmap of doing our secondary assessment. So really, really important stuff. Very, very helpful as far as what we're doing and how we're able to organize our assessment. I tell you, assessment is the key. That should have come from your EMT skills, and you should never learn it. You should always hone those assessment skills by practicing it over and over again. If you're just, take a blood pressure, put them on a monitor, give them a little O2, well, how are you supposed to find out what's wrong with your patient? And let me tell you something. The exams, both National Registry, paramedic, and EMT, 52% is based on assessment. So the multiple guess kind of answer stuff is really gone by the wayside. It is, how's your ability to critically think? They're going to give you questions that say, okay, hey, you responded to this call. It was an 18-year-old complaining of this, and this. What do you think the possibilities could be? Okay, and some of the questions, especially in their scenario based for the medics, there could be 3 answers in one question, and they'll tell you that. So anyhow, let's move on. All right, so A, this is the assessment of the patient condition. Very short and sweet to include the secondary impression. So for instance, now remember, your primary impression is your number one, chest pain, okay? So chest pain, rule out AMI, ACS, okay? Your secondary impression, if you have one, is usually chest pain, shortness of breath. So primary would be your chest pain, shortness of breath would be your secondary. So remember, there can be primaries and secondaries. Usually you have 2 that go hand in hand. In a lot of patients, you just have one complaint, but you can have multiple complaints that you need to make sure that you're describing. Okay. So next is P, plan. This is your course of treatment and your patient disposition at the end of care. So in the P, you got to talk about your vitals. Okay, if they're documented somewhere else that's pulled up in the report, that's fine. But you know that by state law in the state of Florida, you have to have 2 sets of vitals: your initial set of vitals and the vitals before you turn that patient over with. That is state law, Florida statute 401. It requires it. And so you've got to have at least 2 sets of vitals. Don't forget, if you're doing oxygen therapy, you put the SaO2 on both prior to the oxygenation and then after the oxygenation. Did it do any better? End-tidal CO2, I love end-tidal CO2. That's my go-to, man. End-tidal CO2 tells you so much more. It's as close to a blood gas as you can get. 3-lead ECG, that's your initial interpretation. Then 12-lead ECG, any medications that you've given, any procedures, and your transport method. Was it emergency, non-emergency, that kind of thing? And what was the final disposition? Patient was better. Shortness of breath went away. The SAT improved. The end-tidal CO2 improved. Patient's pain level went from a 10 to a 5. And then you turn the patient over to Nurse Smith or whatever the case may be, whoever that person is. So make sure that you get that final disposition. All right, well, we've talked about SOAP. Now let's talk about chart. We're going to move forward here and go over chart in the same kind of way and make sure we cover all our bases. Chart. C, chief complaint. Hey, it's the direct quote. I got chest pain. Okay, that's your chief complaint. That is your C. It also can include information that you've gained in that initial assessment. But once again, this is the stuff that you're being told. Your chief complaint is what's coming from the patient. If the patient's unresponsive, you're getting it from the loved one or the bystander, those kind of things. What is that person's chief complaint? What is your primary complaint that you're dealing with that you're going to have to move forward with and do your assessment on? H, history. Okay, describes a history of present illness or injury. It includes any pertinent negatives. Pertinent negatives are very important. You need to understand what they mean. Past medical history, routine medications, allergies, and all the subjective information that you're getting with. Since you're dealing with a patient, of what they are telling you. Okay, they're giving you this information. They're giving you the history. So this is subjective information. What is a pertinent negative? Hey, pretty easy. Pertinent negatives are clinical findings that specifically are absent, despite the chief complaint saying that, hey, it should be causing this problem. Okay, here's some examples. So for instance, if you have chest pain, a pertinent negative would be they don't have any radiation down in the arm or in the jaw, in the back, that kind of thing. With abdominal pain, they have no rebound tenderness, no guarding, no nausea, no vomiting. It's just diffuse pain, that kind of thing. Headache, no fever, no neck stiffness or confusion. Those are your PERT negatives for that. And then skin rash, there's no itching, burning, or scaling. Those are PERT negatives. Something that you would expect to go along with the chief complaint that's just not there. So you want to make sure that you list that they have none of these things. It kind of gives you a great tool to apply to your differential diagnosis to rule stuff out. Okay. Fever, no chills, sweats, or night sweats. So with that, say for instance, if you're ruling out TB, with TB they have chills, night sweats, and sweats. So if they don't have that and they just have a fever, then it could be just a localized systemic infection. So you just never know. But that's how we apply that for differential diagnosis. A assessment, or AX. This is the objective portion of the narrative. It's what you see. It's what you're doing on your physical exam. It's the head to toe. Your level of consciousness, your vital signs, sick, not sick. I really like that description, and I can go back and change that anytime that I need to. It's simple. It's just a simple kind of explanation that gives us the right pathway to say, okay, we need to get busy on this patient, or we can take a little bit more time. Assessment continued is also skin color, temperature, moisture, those kind of things. Also, obvious injuries, if there is any, and any neurological, neurovascular findings that you find that are deficient, and you want to make sure to note it here. Include those PERT negatives in the findings, the same as the head to toe fashion as you examine. So starting with the head, eyes, ears, nose, and throat, neck, chest to include the clavicles, listen to lung sounds, give that information. Move down to the abdomen, all four quadrants. Move down to the pelvis. If it's a urological or gynecological issue, make sure you cover that in that time. Go down your lower extremities to include distal pulses, motor sensory, and also capillary refill. Do the same thing on the other leg. Don't do them both at the same time. Do them individually. Come back to the upper extremities, do the same thing there, and then perform a neurological exam. Neurological exams are very simple. Smile, give the old squeeze test, squeeze my hand kind of thing. These assessments are important, and you have to do them on every single patient. The only ones that, if you only have a focused exam, I got a splinter in my finger, or I broke my finger, then you're splinting. That's a focused exam. But if you have a general exam or a rapid exam or a rapid trauma survey, we have to hit all of these high points. All right, so treatment, R or RX. That's where treatment comes from, RX, prescription kind of meds. What did you do? Okay, and give it in the order that you did it. Don't start with defibrillation, unless that's the first thing you did. I mean, first you got to examine the patient, establish unresponsiveness, no pulse, and then, put them on a monitor, establish VFib, defib, that kind of thing. Put it in order, as specific as possible. Don't just write down C-spine precautions were taken. What did you do? You did spinal motion restriction, you use a small C collar, those kind of things. Describe whatever it is. Tell us what it is. Don't just give us generalities. All right. Transport, TX, last piece. All right, where'd you take the patient? Cape Canaveral, Holmes Regional. Why? Why did you take them? Did you take them to a stroke center because they were acting like they were having a stroke? Did you call the stroke center? Did you notify them? Did you call us for a STEMI alert? And did you take them to a PCI capable center? Those kind of things. What, if anything, occurred during transport? The patient got better, the patient got worse, those kind of things. How the patient responded to the treatment that you provided is very, very important, because it tells us that you did a good job. You made the right decisions. You gave the right medication. Bada bing, bada boom. Everybody's good. Okay. And then turning that patient over, they'll be much happier with that information. And for me, I know you as a student are comprehensively understanding the assessment, understanding what you're supposed to be doing. This is what I'm looking for when I QA your reports. And if I have questions, I send it back to you and I say, hey, answer me this. Why did this happen? Why did you do this? Why did you do that? Those kind of things. This is really going to come into play during your capstone and also your formative time. So Yeah, you need to give me good information here. The more the better. And I'll be corresponding back and forth with you, give you some feedback on your reports to make sure you're staying within the requirements. All right, so the narrative. Document that you encourage the patient to go to the ED to be treated. The patient understood the seriousness of the decision. They were encouraged that if you have to leave them, if they decide they're doing a refusal, that you told them to call 911 immediately if condition changes or they want you to come back, they change their mind, whatever. The sign release doesn't mean that the patient can't call us back if they immediately are wanted, and you need to make sure to portray that in there, that you told them all the doom and gloom and everything else that could happen. Because in a court of law, if this information's not in there, you didn't do it. And if you didn't do it, you could be held liable. And they're going to go after your agency. If you like a paycheck, you want to make sure that you document this stuff as much as possible so you got good coverage for both you and your agency. Writing tips. No two writers write the same. It's not that big a deal. I've read uh, hundreds of thousands of reports. I mean, lots and lots over the 40 plus years I've been a medic and being involved in QA and QI and QAR and those kind of things. So it's okay. You don't have to be the same. Everybody's got their own style, but you got to have the components. The narratives must be written for all patient contacts, alive or dead. A short version PCR must be written for any refusals that document the reason for no transport. You got to put that in there. Transport crews, hey, they write them and you can get information from them. Whatever report they're writing, hey, man, there's get you a copy if you can, and that'll help you. We also provide you long form PCRs for both clinicals and also for your field time. It's in your dashboard, okay? In case you don't have time to go in and type the information when it's fresh in your brain, you can use the short version SOAP field tool, where it's just a great little, you can fold it up in multiple times. You can have 4 patients on the front, 4 patients on the back. And you can get a lot of information on there to write your narrative in Platinum. Anyhow, we have those longer forms that almost mimic exactly what the EMS crews are using, the transport crews are using. So you need to have some copies of those. If you don't have them, they are on your dashboard. You can download them, print them yourself, or you can get printed copies here at the office. As a student, you'll get information from the crew member writing that report. Use it, writing their report. Get the information from their report. If you can get a copy of it, great. You can get that information and transfer it to your report. All PCRs in Platinum must be submitted within 72 hours of your clinical. I need to look at them. That way, before you come back to class, we can talk about it. And I'm going to be giving you feedback real time as soon as I get to review it. I mean, I've got a lot of students out there, a lot to review. I'll get to them as quickly as possible, give you some feedback, and we can always correspond back and forth through Platinum. Also, a copy of the end of shift report. Okay, that's also available on your dashboard. You can download it. You can have copies printed so you can have them in your clipboard so you can make sure that you've got that information. It has to be done by you and the preceptor and uploaded for all shifts, uploaded into Platinum. The original needs to be turned in at your NICS lab. You can give it to Jay. The instructor can collect them and give them to Jay, whatever, but they become a part of your permanent record. Because let me tell you something, computers can fail. They can crash, they can burn, they can lose all your information. If I have a paper document that's signed by that preceptor, you're golden, and it'll be in your permanent file for 7 years. That's how long we have to keep them. So, hey, it's very, very important stuff to bring that in and turn it in. And Miss J's going to be bugging you about it to get them from you. So make sure you get them turned in at your NICS lab. Remember, good documentation is not only in the patient's best interest, but it's also for your own protection. It's going to protect you. It's going to protect your organization. It needs to be complete. If you're handwriting one, which not very many people are doing that anymore, but some places they might be, it needs to be legible and it needs to be organized. That's why we use SOAP or chart. Either one. It's an organizational method that we use in medicine, period, to make it happen. Bottom line, guys, if you didn't document it, it didn't happen. Plain and simple. Okay, plain and simple. So make sure that we document everything we do for our patients so we can show that we all are competent in our jobs and that our patients are being well taken care of. Okay, end of every single narrative. I want these 5 questions stated and answered. Okay, you can copy and paste them. That too is available to you on your dashboard where you can copy it off a Microsoft Word document, paste it right onto your report, and answer these questions. Okay, here we go. And they're brief, no big deal. What did you observe? What did you see? What did you hear? Okay, that tells me that you are absolutely situational awareness. You are taking a look at the scene, you're making sure it's safe, you're gathering the information, you're being that detective. You're getting that information so that you can properly decide what you're going to do with your patient. That's the first question. Here's question number 2. What interventions were provided and why? If you gave nitroglycerin, tell me why. What's the pathophysiology of it? Why would you do that? If you gave TXA, why? What does TXA do? How could that patient benefit? This tells me that you know what you're talking about, okay? This is all in preparation for not only you being an entry-level medic, but also being a competent test taker for National Registry. They're going to know that. They're going to want to know this. They're testing your competency level, not your ability to memorize the human anatomy or the Krebs cycle or acid-base balance. No, they want to know that you're competent. They're testing your competency and your ability to assess and manage situations. Describe intervention and results. Describe them. You decompressed the chest, air came out, patient could breathe. Pretty simple, okay? Did it make the patient better? Did it make the patient worse? These are the things that I want to know in this question. Question 4, did you deviate from care guidelines? Okay, so it says that I give epinephrine every 3 to 5 minutes. The medic gave it every 10 minutes. That's a deviation from standards or from guidelines or from protocols. So I would want to know why, because I'm going to see that. If you gave the patient glucose and IV, and the patient says, oh yeah, I'm fine, I don't want to go to the hospital, take this IV out of me, I'm all good. So you undo the IV, you get a refusal, that's a deviation from guidelines. So I want to know why and what you did about it. We discontinued the IV, we gave the patient discharge or gave them instructions that they need to eat long chain carbs, you made sure to make them a sandwich kind of thing. Whatever it is you did to make sure that patient doesn't crash and burn when that instant glucose goes away, or that IV push D50 goes away or D25 goes away. Hey, that's we need to know why. Why did you deviate? Whatever it is, and it doesn't happen very often. Most times, this questions doesn't have anything. Just put NA. Don't leave anything blank. I need to know that you addressed it. Each one of these 5 questions have to be NA if you didn't answer them or if there isn't something you got to say about it. And then if I have questions about it, I'll get with you. Anything else to provide? This is number 5. Please include. So anything else that you want to tell me? The code went crazy. It went great. I did this. It was exciting. Hey, whatever you want to tell me. If you had a rough time, if, say, for instance, this was a pediatric patient or an infant patient, and you're a little distressed about it, tell me. I'll seek you out and we'll talk, okay? You can always call me. You can always text me. I need to know these things. If something happens out there, please let me know. I don't know if you don't tell me. And then we can communicate back and forth and we can see what you need and take care of you. So be sure to keep me apprised. All right, that's the end of the 5 questions. And once again, you can copy and paste these right off your dashboard. Where can I find the training document? It's on your JBL dashboard. It's under the section, the block, administrative and course logistics. It's the page or the block, you know. Then if you scroll all the way down to the bottom, I left it on the bottom because, you know, that way it's kind of easier to find. If it's boom at the bottom, you know where it's at the bottom. You'll see a file that says clinical forms, PCR training. Okay. The link to this video is there, so you can always go back and do retraining. I'm going to let you know that this is there. Make sure I'll send you an email and also through JBL messaging that you need to do this training. Okay, so all the documents there, everything's there for you to use. And if you have any questions, you can reach out to me. All right, well, Gay, hey, thanks. Thanks for your time. I hope I wasn't too windy. If you have any questions, please contact me. You can also get with Student Services, you know, Miss J or Kristen, anything you need to know. They've been briefed on this as well. And, you know, reach out to me if you need something. Okay, absolutely. If you need something, you need more clarification, you can text me, WhatsApp me, JBL message me, email me, call me, you know, any way you want to get in touch with me. It's all good. All right, with that, thanks. Thanks very much. And I'm going to let you guys go and live long and prosper. Good luck on your clinicals. Be safe out there. All right, take care.